welcome to the MedEClasses PG lecture series in which we will be talking about a very important and interesting topic of DSD. And this is something which is extremely common, extremely important, and has got huge implications in terms of evaluation and management. So, Dr. Vibha, why do you think DSD is one of the most enigmatic part that we deal in pediatric endocrinology? What are the challenges that are there in terms of evaluation?
So first of all, the identification whether there is a DSD or not, because some of the DSD mimics may cause confusion, and one of the most important consideration is the excess DSD, which is 21 hydroxyl and which is a life-threatening condition. So identification of excess DSD in an early stage is very important to prevent the grave consequences. So in these scenarios, this is important to identify the DSD at the right time.
And what are the common forms of DSD that you encounter in our clinical practice?
The most common that we encountered in OPD is 21 hydroxylase, and the in pubertal age group aromatase deficiency, and rare form of 11 hydroxylase, rarely we do get.
And of course, XYDSD is one of the ones which are
XYDSD, yes,
very
sir, definitely
challenging.
in the boys, XYDSD, 17 beta HSD, and 5 alpha reductase we do
So
have.
XY is something which is often very challenging to diagnose and much more difficult. XS seems to be important because of clinical relevance. So both spectrum becomes important. So what we'll do is that over the next hour or so, we're going to discuss about the pathophysiology, the etiology, evaluation and management of DSD. And at the end, we will have objective structured questions which will be done by Dr. Nimisha. So we'll start off about DSD. And DSD is something which is extremely important to identify, as discussed by Dr. Vibha, because there are lots of implications. So we'll talk about two cases where the diagnosis made a big difference. So we had a 1-month-old boy, child with DSD, who was referred to us with Prader stage 4. And what really happened was there were classical features of XY-DSD. Now, this individual had been given testosterone, 3 doses, and people thought that this is XYDSD. We have done our picture and then we'll go for surgery. But unfortunately, despite the various increase and everything happened, 5 years later developed renal failure. So what's very important to understand is that our job is not just done by identifying a DSD or giving some cosmetic measure. We also have to think of a serious underlying disorder, which could be something like a WT1 defect, which can result in renal failure. So a comprehensive evaluation of DSD therefore is extremely important. The second scenario was more of a diagnostic challenge, a day 3 child with DSD who again presented with Prader 4 with no gonad. So this looks like XX DSD, and on further evaluation was found to have the Mullerian structures, and the karyotype was 46XX, again confirming. At that point of time, a borderline 17 OHP was identified, and based on that, a diagnosis of 21 hydroxylase deficiency was made, and the child was labeled for life in terms of treatment. Now, what happened by the treating physician was that they found that they could actually cut down on the dose of hydrocortisone, and the 17 OHP remained normal, which really excluded CAH as a possibility. If you look in retrospect, the amount of 17 OHP elevation was not remarkable, and this brought us to some alternate diagnosis. And when we evaluated, we found that there was delayed puberty. Now the child presented around 14 years of age with delayed puberty. On retrospect, there was a history of maternal virilization, giving a clue to aromatase deficiency. The key message is that if you identify XYDSD, don't just get satisfied with the diagnosis and treatment, think of an underlying cause. And not all XXDSDs are CAH. This is something which is extremely important to understand from that regards. All of you can go and have a look at our website learning.society.in, which has got multiple source courses and resources, including fellowship in pediatric endocrinology, our e-learning platform, the YouTube channel, which has got large number of information available. We have got courses which are available, and including fellowship and postgraduate programs which are there, which can be accessed online as well as on a hybrid mode. We run regular programs in the form of grand rounds, journal clubs, and PG lecture series. This lecture series is part of a 36 lecture series which aims to cover the entirety of pediatric endocrinology over a 3-year period. We have already conducted around 15 such lectures. They are all available on YouTube. You can go and have a look at that in detail in terms of that. There are multiple publications which provide coverage in terms of pediatric endocrinology, right from protocols to basic and to advanced pediatric endocrinology. Our latest application is now available on both Android and iOS store. It looks into entirety of pediatric endocrinology. So we'll talk about PG lecture series. I'll be joined by our consultant in pediatric endocrinology at Regency TDR, Dr. Vibha, who will be talking about etiology, and Dr. Nimisha, our fellow, will be talking about some very interesting cases. Have got palpable gonads, and then we want to look at whether there are other Mullerian structures or not. So if there is no palpable gonad, Mullerian structure is present, that is most likely to be a XX-DSD. The most important thing to look here would be a 17-OHP to look at CAH, and DOC also if there is a feature of 11-hydroxylase deficiency. If they are high, this is congenital adrenal hyperplasia. If these levels are normal, we are dealing with aromatase deficiency or dysgenesis. If there are palpable gonads and Mullerian structures are also present, we are dealing with complicated disorders where AMH will help us classify. If AMH is low, this is dysgenesis. If AMH is high, this will be AMH resistance. If, however, there is no Mullerian structure, whether the palpable gonad is there or not, this means that the gonad was there sometime. This could be anorchia, this could be dysgenesis. Go for testosterone. If it's low, go for salt status. There is salt wasting, that is star, side chain cleavage, Smith-Lemeli-Opitz. If there is hypertension, that is 17-hydroxylase deficiency. If the salt status is normal, we could be dealing with the LHCG receptor defect or 17-beta-HSD. While if the testosterone is high and DHT is low, this is 5-alpha, and DHT is high, this is AIS. So the whole diagnosis that we are using is mainly clinical. We're looking at palpable gonads and Mullerian structure, and then classifying based upon the salt status, the blood pressure, and also some basic investigations like AMH and other parameters. So you don't need to have extensive evaluation. Basic concepts will be able to help you out in terms of classification. We have developed a simplified tool which allows evaluation, assessment, and management of DSD, which is the DSD interpreter. Now all you have to do is to basically put in the data, whether there is a Mullerian structure or testosterone. You put the results based upon the requirement. So it will only ask for tests which are relevant. And once you put those results, it will give you an appropriate diagnosis from that perspective. So this is one tool. Whatever we have talked for the last 1 hour can be implemented immediately, instantaneously from that perspective. So we'll start off with a few cases. 3-week-old child with DSD, no palpable gonad and micropenis. So it was referred as no palpable gonad and micropenis, but actually if you look at this child, there is an atypical genitalia. This did not need reassurance and presented with salt wasting. So if you look at the basic data and evaluation from that perspective, if we use the interpreter, we'll clearly talk about the need for 17-OHP, which will give us a clue that this is a 21-hydroxylase deficiency from that regards and perspective. Day 3 child, again, this is what we discussed, that this is a child who has stage 4 Prader with no gonads, going more in favor of XX-DSD, uterus is present. Now 17-OHP here is not high. So what do we do here? There is maternal virilization, and this is indicative clearly of a possibility of aromatase deficiency. And if you feed in our data, it will again go through. So if you have an XX-DSD who has got a normal 17-OHP, think of a possibility of alternate diagnosis like aromatase deficiency in that regards. 3-week-old child with atypical genitalia, again stage 4 with no palpable gonads. Mullerian structures were present, and we have got hypokalemia. So again, this is a very, very important clue. This is a 11-hydroxylase deficiency. So if you look at the basic workup, the algorithm will give you the diagnosis very clearly. A day 14 child with DSD, what we see that there is a bilateral gonad, there are no uterus, and this is a 46XY individual. Now, if we look at in terms of the information, what we find is the testosterone is low. There is hyponatremia, there is hyperkalemia. So this is a XY DSD with a salt wasting scenario. So this is going more in favor of a possibility of 3-beta-HSD deficiency. 6-week-old girl with failure to thrive. The weight is not increasing. There are bilateral gonads, although reared as a female. Now, the Mullerian structures are absent, so this clearly means that we are dealing with typically a scenario of a XY DSD. Now there is salt wasting, so there are very few differentials here. We're looking at star, side chain cleavage, POR, and think also of a Smith-Lemeli-Opitz syndrome as well. There is syndactyly, which I discussed is a pointer to SLO. There is an upturn near, and this is Smith-Lemeli-Opitz syndrome from that perspective. 11-year-old boy with early puberty. The child is short. Actually, this is presented as a boy, but on examination, there are no palpable gonads. So we have got a apparent boy with bilateral cryptorchidism with stage 4 pubic hair, which means that there is some other place from which the hormones are getting produced. And what we found here that the uterus was present. This karyotype was XX, and this turned out to be a hypertensive variant of 11 hydroxylase deficiency. So this was a XX individual who presented as a boy with precocious puberty and palpable and absent gonads and hypertension. 3-month-old child with atypical genitalia and palpable gonads were there, but there is no uterus. So again, this is a classical case of XYDSD. Testosterone levels are low. The sodium levels are normal, so there is no salt wasting. This happened to be a 17 beta HSD, so this is an isolated defect. So once you have testosterone deficiency, look at hypertension. Otherwise, this could be an isolated biosynthetic defect. 1-month individual with atypical genitalia, very interesting case to highlight because this tells us about diagnostic issues. There is palpable gonads which are there. Uterus is absent, and this is 46XY. Electrolytes are normal. Testo to DST ratio was huge. So this was suggestive of a 5-alpha reductase deficiency. But we have discussed that you can often have discrepancy in terms of genetics. So when we did the genetic diagnosis, this happened to be a form of a partial AIS. So biochemical tests are not 100%, and therefore genetics needs to be done more frequently from that regards. 10-year-old girl with clitoral enlargement, phallic size was 2.2. So she was reared as female, and now the phallic size is increasing. There are bilateral gonads which are present. The uterus is absent. So what we're dealing here is that gonad present, uterus absent. So this is clearly going in favor of a XYDSD. This is somebody who is virilizing during puberty. So what we are looking here is high testosterone. We are looking at high testosterone to DHT ratio and 5-alpha reductase deficiency from that regards. 15-year-old girl with delayed puberty. Again, there is inguinal gonad. So this is opposite of that boy who had come, quote unquote, boy with precocious puberty who had come to us with this scenario. This girl has inguinal gonad and delayed puberty. There are no Mullerian structure. So we are clearly dealing with a scenario of a XY individual. FSH is high, testosterone was low, and an important clue here was there was hypertension. So a girl who has sexual infantilism and hypertension, think of 17 hydroxylase deficiency, particularly if there is hypokalemia, and if there are inguinal gonad, this is a XY individual with 17 hydroxylase deficiency. So DSD can be a bit confusing, but if you look at this algorithm, look at palpable gonads, Mullerian structures, and blood pressure, you will get the diagnosis in most cases. Another case, 15-year-old girl with primary amenorrhea. Height is normal. There is stage 4 breast development, sparse pubic hair, and inguinal gonads. What we are finding is that uterus is absent and karyotype is XY. So this is again XY DSD. And if you look at this scenario of classically stage 4 breast development, no pubic hair development, it means that the androgens are there, but they are not working. They're getting converted into estrogen. So this is a classical scenario of a complete androgen insensitivity syndrome from that regards. Finally, we have a day 14 child with asymmetrical right genitalia, and the uterus is present. This is an XX individual. If you look at the child, one side we have a female appearance and the other we have the testicular development. So this is a classical scenario of a case of over-testicular DSD. So we have tried to go through a large number of cases to give us an overview in terms of different aspects of DSD. Linda is asking what atypical DSD with both gonads palpable, chordy and penoscrotal hospitalaria, but no Mullerian structure. So obviously this is a XY DSD. Now here what she has found is that karyotype is XX and 17 OHP is not detectable. No features of salt wasting. What type of DSD am I dealing with? So this is a very interesting scenario. We have a child with atypical genitalia where gonads are there, but there are no mammalian structure, which means AMH was produced at some point of time. So first of all, I will like to really look at whether the karyotype was right or not, because that is the first thing I would be a bit concerned, because this looks like a XY-DSD. If you're looking at XY-DSD, then XX-DSD, then we are looking at maybe issue in terms of SRY insertion or some other cause which has caused this development to happen. So this is an interesting case. Probably go to the, again, go ahead and look at what's happening in terms of karyotype, whether there is an error, and then we can go forward from there. Dr. Seema Rai is asking about a girl with suspected XXDSD with CH. Salt wasting was present, neonatal age group, and put on hyphone and fluorocortisone, but 17 OHP was never high. Okay, it was never high, always NGS strain, but no mutation was detected. So what can be the reason? So we are talking about a XXDSD with salt wasting. Now this is a bit interesting. So how severe was the salt wasting? If the 17 OHP is so low and exome sequencing is not finding that, I'll question the amount of salt wasting. So if there was really 21 hydroxylase with 17 with salt wasting, you would need to continue on a high dose of hydrocortisone and fluorocortisone till now. So I think we can think of some other forms of XXDSD which can cause that in that perspective. We have a question about, is it necessary to do gonadectomy in partial gonadalogenesis? Very, very important. Partial gonadalogenesis does require gonadectomy. We have not addressed that issue, but definitely it is required. In most of XY-DSD, testosterone treatment is necessary to evaluate the full diagnosis. Again, very, very important, because you can have implications like malignancy risk, implications like renal failure, implications like other things. So XY-DSD, at least reaching a reasonable diagnosis is important, because it's not just testosterone. As we showed the first case who ended up in renal failure. So you have to be cautious in that regards, and there could be other issues about salt wasting in that perspective. So I think we had a very, very long session, but a lot of people are still there. So thanks all of you for joining from across the world. So this was an interesting session. And again, I'd like to thank Dr. Vibha and Dr. Nimisha for the wonderful presentation that were made. And we will join again